would like to thank the organizing committee. It's a great initiative to everyone who works with the neurological diseases and any other conditions associated to ICP changes, not only acute, but the goal of a symposium like that is to raise a discussion about the potential application of these methodologies and how much patients may benefit from that. So I am here to talk about the non-invasive ICP monitoring in TBI. And the neurocritical aspects where we use intracranial pressure concept and the possibility to apply non-invasive tools and its huge potential. Non-invasive monitoring, to talk about non-invasive monitoring, we have to understand the aspects about invasive monitoring. Since Mohokel concepts to cerebral compliance concept, pathophysiology of intracranial pressure, until the 60s and 70s when we effectively started measuring intracranial pressure, treating a patient with ICP, and to understand that ICP is the main death cause for patients with the TBI. That seems to be a patient with arterial pressure. You're going to treat the patient with the blood pressure without knowing exactly what that pressure is. Well, that doesn't make much sense, does it? However, monitoring was part of the clinical practice in the 70s, but much has been discussed so far. The monitoring standard is still the invasive one, which leads to clinical issues, bleeding risks, infection risk. Costs, which becomes a problem for low-income countries. The use of invasive monitoring, according to the American Foundation, we see differences in the way they apply those tools in low-income countries. So non-invasive methodologies prevent associated complications, and simultaneously it allows cost reduction thanks to the development of new protocols for non-developed countries. As the incidence of trauma, it becomes more relevant in this populational range, Asia, Africa, where there is a higher incidence of TBI. And the current recommendation, according to the Brain Heart Foundation, is to reduce mortality in 2 weeks. That is a consequence of a study coordinated by a Seattle group, which assessed protocols using non-invasive monitoring, and they were not able to identify differences in late outcomes. Some meta-analyses were conducted, and the main trial affects meta-analysis, but the protocols that we are applying at our services in Brazil, they are still using intracranial monitoring as the main patient's follow-up protocol. There are some cases where we haven't got invasive monitoring. Then we may apply a more rigid protocol. with non-invasive methodologies. That publication led to a number of practical issues. Health Ministry, Conitec, and some other agencies that questioned invasive monitoring. Then we want to understand what would be the important aspects to keep monitoring as a standard protocol. We believe that patients monitoring is key, but how to do it? Well, that's something else. And protocols compliance for ICP monitoring, they are stronger for those patients that undergo ICP monitoring. And we have to monitor intracranial pressure that may be invasive, but that is not, if that's not available, if we have any questions or issues about how can we apply that as tools, as non-invasive tools, how can we conduct that without AICP monitoring? And how is that monitored? There are some tools like the standard protocol, but there are the non-invasive ones that may be used, and each one of them have their own benefits and restraints. But in a setting where invasive is questioned and not available due to costs, training, transcranial Doppler. This is a methodology described back in the 80s, and thanks to a transcranial Doppler, you may perform an assessment of the self-regulation and analysis of the macrovasculature of patients, where they identify regulatory standards, hyperkalemia, working in association with Professor Shu, assessing the use of Doppler at different scenarios of intracranial pressure, especially with the patients with TBI. There are some parameters to be applied, such as to identify circulatory standards of hyperemia, the dynamic and static self-regulation, pulsatility, and a number of other articles which were recently published. We published that like 10 years ago, but we have to better understand about the hemodynamic concepts, and that would be so interesting for patients like that. Although that is a useful tool to be applied, there are some limitations, some advantages and disadvantages. As advantages, it may be applied in real time to measure hemodynamic cerebral activities, and also you avoid unnecessary intrahospital dislocations. According to patients' safety evaluation, dislocation intra-hospital, they lead to additional risks, accidental risks, and also they may have decompensation of pressure, CO2 increase, a number of issues that may take place due to unnecessary dislocation. So if we have any Doppler that will avoid such a necessary dislocation is key. Even in our clinical practice, sometimes the patient has an ICP of 25, 30 once in the OR, and then at the time we should start surgery, the patient has an ICP much higher, around 40, 45, because of the transportation, the dislocation. Transcranial Doppler has a relatively low cost and may be applied several times. Disadvantage, operator dependent, which requires a long training, additional provider skills. There are some criticisms about the use of indirect variable analysis of ICPs, and that may be same as a disadvantage for the use of this tool. But yet, transcranial Doppler may represent an additional tool for neurologists or intensivists. But still, that requires a longer learning curve where all evidences and information will be of high confidentiality. Optic nerve sheath, where we are able to measure that sheath diameter, we'll be able to calculate the distance or the dimension of the optic nerve sheath, and we see in the literature the need of this correlation that can be done during sonography, and ideally the average would be around 5.7 millimeters of mercury. With high sensitiveness for ICP. Of course, that anatomic issues in pediatric patients should also be taken into account. And in pediatric patients, we have to consider the optic nerve sheath measurement, which in average shows 4.5 millimeters of the optical nerve sheath with a correlation of 20 millimeters of mercury. Anything above that represents ICP, and below it, it's a normal tensile pressure. Another advantage of applying optic nerve sheath is that you may use the training curve. The learning curve, I better say, sorry, the learning curve is short, and with ultrasound use, you may reach a good accuracy level. However, we still find some obstacles in estimate optical nerve sheath and higher levels of intracranial hypertension. This is an article published 1 year ago, where we estimate intracranial pressure by ultrasound of the optic nerve sheath in an animal model of intracranial hypertension. Findings were positive, where interventions to improve intracranial hypertension, they are effectively also to decrease the optic nerve sheath. And that information was precise because that sheath optic nerve information can be helpful on experimental model where there was a correlation between the dimension of the optic nerve sheath and invasive ICP in a group of 30 animals, swines.
The main question we have is, what is the behavior of the system when the pressure is higher? With 7 millimeters, the model in humans there is a correlation of 20 millimeters of mercury. But what happens when the pressure is 30 or 35? Is there still a good coefficient of correlation among those two methods? So this is one of the main questions in the literature for the use of this tool as an exclusive tool to monitor ICP. So we use this tool as a one-off tool and maybe used for screening purposes in patients that are undergoing monitoring. 34-year-old patient. Here we can see the point, so 3 millimeters behind the eye fundus, so measuring the optic nerve sheath, so above the range of 0.5 to 6.5, which indicated of 20 millimeters of mercury. CT scan, acute hematoma, subdural hematoma. Here the surgery, removal of the hematoma. Ultrasound first post-op, showing the improvement of the optic nerve sheath, indicating there was an improvement of intracranial pressure as expected once the hematoma was removed. This is the post-op image, and the patient was discharged. The correlation between the optic nerve sheath diameter and CT scan has already been subject to studies showing a positive correlation between outcomes and the diameter of the optic nerve sheath, improvement in survival rates, in functional recovery. And there are some studies showing a correlation between optic nerve sheath diameter and some CT scan scores, especially Rotterdam score, showing a correlation with survival in a scenario of intracranial hypertension. So an optic nerve sheath diameter, as the advantage has in a real-time evaluation, no intra-hospital transfer is required, low cost. The hospitals have ultrasound available, so there is no cost associated to it. The main advantage is that it's a fast learning curve, different from transcranial Doppler, which is more complex. Fast learning curve with interest correlation. The main disadvantage is that it's not possible to have continuous monitoring. So it's a specific time measure, and we don't know exactly how long it takes. A patient I measured, let's say, optic nerve sheath diameter. So I offer hypertonic saline solution, and how long does it take for the optic nerve sheath diameter to respond? Our animal model seems to be a quick response, but there is no clear answer about how long it takes in humans to have changes. So it should be used as a screening tool for patients who are undergoing invasive ICP. This is another case, 53-year-old patient. The patient had a car accident. CT scan, we can see traumatic subarachnoid hemorrhage. We've used transcranial Doppler. It showed high pulsatility index. So we decided to sedate the patient. CT scan did not show major edema, showing progressive improvement. And then the patient could be weaned from sedation. Another case, 45-year-old patient. We can see here hematoma. Optic nerve sheath was 6.4, showing a correlation with ICP, high ICP. Transcranial Doppler showed high pulsatility index. We use the number of clinical improvement until final weaning of sedation and improvement of the patient, just showing in practice what our tools are. Another recent tool, which is of course the topic of this symposium, is the use of brain for care, non-invasive ICP monitoring, thanks to the exceptional work carried out by Professor Sérgio Mascarenhas. So it involves the concept of the diversity of all the classical concepts that date to 200, 300 years. They are like dogmas today. But Professor Sérgio Mascarenhas just embraced the challenge. And as a result, we could study further the topic and just have another tool to monitor our patients. We can be researchers, but ultimately we want to provide better care to our patients. We all have the vocation of caring. As researcher, yes, we think collectively, but as physicians, we always have a patient in mind. And we can see a huge potential for the use of this dose. So detection, bone transformation is observed. The system captures that, transmits information to a screen that shows a qualitative analysis of intracranial pressure. The system seemed to be minimally invasive at first with an incision on the skin, but now it's a non-invasive system, which is the main benefit. And as I've told you, there is a qualitative analysis of intracranial pressure, observing the waveforms. And we know the importance of qualitative analysis. It's not only what is ICP, what is an absolute number. Optic nerve sheath diameter is an isolated piece of information, so 6.5, but it is not enough to manage our patients with intracranial pressure. The use of concepts of qualitative analysis of ICP curve provides the detection of cerebral compliance changes, which are directly correlated with decompensation of ICP, what's the right moment to wean from sedation, or adopt other measures to control ICP. There are groups that have carried out different studies in addition to cranioencephalic trauma or brain trauma. If in an infectious case, both in pediatric and adult populations, showing the use of the tool. Our group has working closely with Brain4Care's team, and Sérgio Brazil is our liaison. He is a neurosurgeon. He has been adopting transcranial Doppler and others tools, and this is his postdoc study. Patients in a neurocritical care, and the tool was used for the population at different levels. This is an analysis, 41 patients. Most of the cases were TBIs. There were also some cases of SAH. Hundreds of points were analyzed, and basically what we can see in the curve as shown on the charts is P2, P1 ratio, time to peak, and the amplitude. The three pieces of information provided by the system in addition to qualitative analysis by observing the waveform. And we can see clearly the different ICP curves from the arterial blood pressure curves. Of course, specific training is required, but the main advantage of this method is that it is easy to understand. But of course, training is required to be able to appropriately capture the intracranial pressure curve. In the study, we have the analysis of patients with closed skull with craniotomy of fractures and craniectomy, showing the potential of application of the tool. We can use continuous monitoring, even in patient after a decompression craniectomy. In the past, it was believed, oh, I have already decompressed, removed the bone, there is nothing else to be done. But we know there is a correlation of outcomes of patients that maintain ICP hypertension. In an invasive model, it's much more aggressive. So a patient with an ICP, which is too higher, tend to have worse outcomes. There is a study showing that 14.7 is a cutoff point that shows increased in mortality. So it's important to observe these patients after decompressive craniectomy, comparing invasive monitoring of ICP and the brain forecap. This is another paper published in Brain Science by our group. It's the postdoc result of Sérgio, Brazil, analyzing waveform in non-invasive models. There were 57 patients divided in 3 groups: intact skull, patients submitted to craniotomy, and patients with no bone. Most of the patients had a TBI, few patients with cerebrovascular disease, some with subarachnoid hemorrhage. We can see here the comparison of the skull and the P2 over P1 ratio in all the different disease groups, showing once again a very interesting correlation between the invasive monitoring of ICP and the non-invasive model of ICP, using some of the variables, P2 over P1 ratio, which is what's widely used, some resulting data together with Robson Green from Manaus, who also worked with us in São Paulo, showing some cases. We have here invasive and non-invasive monitoring, and we can see a closed analysis and once again a coefficient of correlation which was very high. This is a very interesting method. With some dozens of patients, and the results have proved to be very effective compared to invasive monitoring. We are carrying out a multi-center study involving 5 of the key centers in the country: Hospital das Clínicas, João 23 in Belo Horizonte, João Lúcio in Manaus, Trauma Hospital in João Pessoa, and Hospital Miguel Couto in Rio de Janeiro. Correlating the results with a larger sample, providing a quantitative analysis based on the 3 pieces of information of non-invasive monitoring. It's also possible to use PRX as a calculator. This is a very interesting chart showing the comparison between invasive PRX and non-invasive PRX. Intracranial pressure and mean arterial pressure. The closer they are to 1 in terms of correlation, the better the preserved of autoregulation and compliance of the patient. And there is also a correlation with patient outcomes showing that we can use non-invasive PRX for these patients. What are the advantages of using this tool? In real time and continuously, we can analyze ICP. We can also analyze PRX, relatively low cost. And it opens the doors for other potential applications, both in clinical practice and in research. The disadvantages is that there is still no absolute precise number for ICP. And the team has to be trained to be able to position the patient accordingly. The use of these non-invasive methods is really important for all neurocritical diseases, especially for low and mid-income countries where we have a huge potential. So really a great potential of application. Thank you all very much for your attention. And thank you for the invitation. Dr. Wellingson Paiva, thank you very much. Excellent presentation and very exciting results. Really showing the applicability of this science. There is a very quick question, so I would like you to quickly answer it as well. Considering all the technology and knowledge generated throughout the years, what can we expect of the next guidelines of the Brain Trauma Foundation? Ideally, we expect to see changes. The problem is the 4th edition in terms of monitoring. Everyone was not very sure because of the publication of the Petrum trial. But the idea is to have a number of modifications. Now, in the second half of the year, in 2022, we are going to be part of an international consensus in neurocritical patients for the European Society of Neurosurgery and the Neurocritical Care Society. Therefore, the next edition of the guidelines of the Brain Trauma Foundation will probably bring additional information about the use of non-invasive tools, because we know the literature has been consolidated, bringing evidence towards this consensus of specialists, bringing this additional support for the use of these tools. That's great. Thank you. Thank you very much. Excellent work. And we are looking forward to seeing future results of your research and activity. Thank you very much. Let's now go into our next talk.